Hi, Sam here, and I am submitting the first of 4 videos for our appendectomy assignment. This one is the critical analysis, or critical appraisal rather, of a meta-analysis, and I chose to do the Varadhan meta-analysis. So, the first question that I addressed for critical appraisal based on the JAMA template was, first I chose to define what the PCOS is. So, I said that for the P, or the patients, that these are adult patients with uncomplicated acute appendicitis. For the intervention, I said that it was antibiotic treatment, and it's important to note that based on the instructions for the assignment, I chose to look at all antibiotic treatments as equivalent. For the comparator, I said that it was appendicectomy. And for the outcomes, this study broke them down into 2. So primary outcomes, which was complications, specifically relevant complications reported by all studies. And the secondary outcomes were length of hospital stay, readmission, efficacy of treatment, incidence of perforation, pain, and body temperature where available. And the S, or the study design for this PCOS, was a meta-analysis of randomized control trials. So, the first question in this template is the question appropriate? I.e., is it too broad or narrow? Now, I broke this down into the components of the question, so the PCOS. I think that the question is appropriate for the patient because adults with acute uncomplicated appendicitis seems appropriate. It's specific enough to be looked at through a variety of studies, but it's common enough to still be useful in practice. The I is antibiotic treatment, and as I already mentioned, I think that it's important to note that although this is a broad category, it's unlikely that a review of literature would find enough randomized control trials on the exact same antibiotic and mode of administration. So in order to have enough studies to conduct a meta-analysis, lumping them all into antibiotic treatment seems appropriate. The comparator as appendicectomy, this seems appropriate because it's the standard practice for acute uncomplicated appendicitis as far as I know. The outcome, this primary outcome seems appropriate, complications. Seems appropriate because it only includes 3 items to define complications, so it's not a gross composite endpoint of many different factors. Also, I liked that they defined complications in the same way, or in a very similar way, for both the surgical and antibiotic group. This helps to reduce the bias when making comparisons between the 2 groups, because if they were defined differently, that would be a very biased comparison. The study design seems appropriate because there are a few randomized control trials available, so it seems appropriate to synthesize these results, and also very useful from a clinical perspective. So the next question here is, are the results valid? And the first question related to that is, did the review include explicit and appropriate eligibility criteria? So first I looked at, are the results likely to be similar across the patients included? Now, all the patients were adults with acute appendicitis. This is diagnosed by a variety of methods, but they all seem to ascertain the diagnosis reasonably well. It's important to note here that I'm assuming that a CT scan, a planned appendicectomy, and a certain C-reactive protein level, I'm assuming that those are all equivalent in their ability to diagnose acute appendicitis, given that I don't have the clinical background to know different. However, one study only enrolled men, which may lead to differential outcomes and is certainly a cause for concern. Another beneficial factor, is that this meta-analysis only included studies for which randomization occurred. There were no observational studies, and this is important because randomization helps to ensure that the characteristics were similar between the intervention and the comparator group. So the next question I asked myself is, are the results likely to be similar across the interventions and exposures studied? I said yes. As per the instructions, I'm assuming all antibiotics are equivalent, and I'm also assuming that all surgical treatments are equivalent. Again, I don't have the background to say that they are not, so it's just important to note that for this assignment, I'm assuming that they are. So, are the results likely to be similar across ways in which the outcome was measured? In this case, yes, because the outcomes are fairly objective. The primary outcome, complications, was measured by a variety of techniques, including CT scans, surgery, wound infection, or perforated appendicitis. Secondary outcomes included length of hospital stay and readmission, which are mostly objectively measured variables. So, did it turn out that the results were indeed similar? For the primary outcome of complications, yes, and I'll get into this later when we look at the variety of outcomes. But for the secondary outcomes, no, and the heterogeneity was too large. But again, I will get into that later on. So, was bias selection and reporting of studies unlikely? And for this I asked myself, was the selection of studies detailed and exhaustive? The authors do a great job of detailing their methods for searching for literature. They give a list of databases, keywords, and Boolean operators. Authors also conducted manual searches of bibliographies. This seems detailed and exhaustive, especially when we consider the fact that only 4 studies were included. I would hazard a guess that the authors would have liked to include more, but they probably did a detailed search and only found this many. And they also searched for studies regardless of their language, which is another sign of their thoroughness. They did address publication bias. A funnel plot did show a risk of publication bias, they said. So I would think, therefore, that authors may have wanted to search for unpublished literature if possible. So that's definitely a bit of a factor that I would like to consider, and that there is publication bias here. So were the primary studies of high methodological quality? Now, the authors used the grade criteria to assess the quality of each study. For the summary of findings, the studies are found to be of moderate quality. However, when we look at Table 3, we see the overall quality of the evidence is often low, and low to moderate at best. So this is problematic in my view. But overall, given that the authors were presumably looking to include the best quality evidence that they could, and that given that grade is based on the best available evidence, this seems reasonable, especially given that there were only 4 studies. Were assessments of the studies reproducible? This is a definite yes. The grade system and Grade Pro software is available online and is certainly reproducible. Also, the authors indicated why studies were downgraded in Table 3. So, what are the results is the next section. I broke this down into 3 different results: complications, length of stay, and risk of complicated appendicitis. And for all 3, I looked at only the forest plot that included all 4 studies. So, for complications, were the results similar from study to study? For this, I looked at the point estimates. They seem moderately similar. The confidence intervals also overlap, which is good. A p-value test for heterogeneity was not significant, and the I-squared test is 0%. Furthermore, visual inspection of the forest plot, complications looks homogeneous. So that's a positive aspect. Where the overall results of the review was a risk ratio of 0.69. This indicates a protective effect of antibiotics compared to surgery and was significant. The results seem reasonably precise to me, with a confidence interval of 0.54 to 0.89. Now, I'd like to note that this seems reasonable given there were low levels of events, which can widen a confidence interval more so than a low sample size. So given that, I think that the results were significant, reasonably precise, and homogeneous for complications, which is good for the interpretation. So moving on to their secondary objectives, length of hospital stay. The point estimates are not similar for this. There is a considerable difference. The confidence intervals do not overlap, although they do come close. The p-value test for heterogeneity is significant, and the I-square test was 70%, which according to our JAMA book, an I-square over 50% is a cause for concern. So, the visual inspection of the forest plot also looks borderline, I would say. They're not drastically different, but the heterogeneity of these studies is certainly a cause of concern and affects our interpretation. Now, the risk ratio found for this outcome, length of hospital stay, was 0.2, and it was not significant, suggesting that antibiotics or surgery has no impact on the length of stay. And I did think that they were reasonably precise. So, moving on to the next outcome, which is also a secondary outcome, I should mention, what was the results of the risk of complicated appendicitis? The point estimates for this are not similar. The confidence intervals do not overlap. The p-value test for heterogeneity is significant, and the I-squared test is large at 82%. Now, there's an important thing I'd like to point out about this. when we look to the visual inspection of the forest plot, this plot has a very large scale in that the risk ratio at the left-hand side is 0.002 and the risk ratio at the right-hand side is 500. This is very deceptive because at a glance these studies do not seem to be too heterogeneous, and it seems that they would be able to be interpreted as is. But when you consider the scale, they are certainly heterogeneous. For example, it looks as though Hansen and Styrud have similar estimates. But when we take the scale of this forest plot into consideration, the upper bound of Hansen is actually 0.3 less than the lower bound of Styrud. This highlights for me the importance of assessing heterogeneity in multiple ways. Although it can seem redundant to look over point estimates, confidence intervals, p-values, heterogeneity, and a visual inspection, it's very important because in this case, just a visual inspection would have missed very important heterogeneity factors. So, the overall results of this review of risk of complicated appendicitis, I should say, is not significant. And the results are not very precise. So, another thing I'd like to point out here, though, is that they only reported forest plots for 2 of their secondary outcomes. So there are no forest plots drawn for readmission or for efficacy of treatment. This makes me a little skeptical of why this is, because there isn't an explanation given. So, moving on with our template, how can I apply the results to patient care? And for this I considered the question, were all patient important outcomes considered? I think that all the outcomes studied were certainly important. I would normally argue that one should always look at all-cause mortality as a patient important outcome, but I don't think that this is necessary since the risk of death from acute appendicitis was noted to be low by the authors. Now, I should note that I'm assuming the authors are correct in saying this, and I did not independently verify this. I would have liked to see more focus on pain, but I understand that the authors were limited in terms of what they could report on, because it depends entirely on what the randomized control trials reported on themselves. So, are any postulated subgroup effects credible? This isn't really that applicable here because no subgroup effects are reported. This is good as it makes it less likely that the authors were fishing for significant results. Authors did report separately for studies that did not allow crossover of patients, but I think this is reasonable because this is an issue of differing methodology, and it's doing a subgroup analysis in a way to see if different methodology and different inclusivity of studies affects results. This isn't a different subgroup of patients necessarily. So in this case, I think that it's fine. What is the overall quality of the evidence here? The overall quality was low to moderate. Now, I would normally argue that meta-analyses should exclude low-quality evidence, but grade is based on using the best available evidence. And there ended up being only 4 studies considered, which I think is reasonable within the parameters of grade to include some low-quality ones if it's all that's available. So the final question, are the benefits worth the costs and the potential risks? I'm going to say no here. In my opinion, as I already mentioned, the authors were correct to include the best available studies in their meta-analysis, rather than excluding low-quality evidence when little else was available. However, it becomes a different issue when I'm looking at actually applying this analysis to my patients. 2 factors make me skeptical about saying that the benefits, which in this case would be a lower risk of complications for the antibiotic group, saying that these outweigh the risks of not having surgery. So the first factor, I'm not willing to advise patients to avoid surgery from a meta-analysis of only 4 studies. I understand the merit of doing it to synthesize the available evidence, but it's still not enough for me to change my findings. Second, I'm not swayed from the current gold standard of surgery based on studies with low methodological quality. Therefore, I think that the benefits are not worth the risks, and we should continue to advise surgery for adult patients with acute, uncomplicated appendicitis.